Hi, this is Brian Kim. I'm going to share with you case number 31 in the Best Way to Do Cataract Surgery series. This is a medium pupil and medium density lens. This is a completely unedited case. And I want to show you this case because it highlights that I don't rush through the case. I want to do every case as if it was my own family member, which means I take my time. I want to be very precise, very methodical, keep ultrasonic energy to a minimum, protect the cornea, protect the iris, protect the posterior capsule, and you'll see utilizing mechanical fracturing techniques, double chop, cross chop, and doing my hydrodissection technique and the way I do it, keeping the eye completely inflated during the entire case. These small, subtle things is why I do the surgery the way I do it, even though it might take a little bit longer to do it this way. So I'm going to use my corneal marker to help me center and size my rhexis. You can see I'm using a cotton tip to hold the eye straight, so I have the corneal mark centered over the center of the pupil. I'm using my diamond blade to make a paracentesis, first on the right and then the left side. I try to make my incision flat to the iris plane, parallel to the iris plane to get a nice corneal shelf, and this helps me hydrate the incisions to get a good self-sealing incision. This is some intracameral lidocaine to help numb the inside of the eye. We typically inject intracameral lidocaine first, and then if the pupil is borderline, we'll also inject some epinephrine. And so this pupil is borderline, so go ahead and inject some epinephrine. And with this, I like to inject it on the surface of the iris and then under the iris as well to get maximum effect. So now I'm injecting some dispersive viscoelastic starting on the other side and then pushing that bubble out of the incision. And then I'm getting my keratome blade ready. I'm using the cannula to hold the eye, make my vertical groove, and then use a cannula to push the eye away a little bit, enter the blade into the groove, tunnel through the cornea, and then I dimple down and then enter, and that's the triplanar corneal incision. With my teeth closed, I open the wound and then go in with the forceps, puncture centrally, drag it inferiorly towards me. But sometimes the tear isn't quite perfect, and so again, these aren't sharp tip rhexis forceps, and so sometimes the tear is not consistent. So you find the tear and start working with it, going around circumferentially. I'm following the corneal marks to help me center and size the rhexis. It also helps that the pupil is nice and well centered, and so I'm following the contour of the pupil as well. And then I burp some viscoelastic out of the eye. Decompressing the eye helps for the hydrodissection. This is my capsular fornix hydrodissection technique. Place a cannula out to the contralateral equator into the capsular fornix, pointed downward, and then you get a nice fluid wave. I'm decompressing on the left side and then on the right side, and then pointing it downward, and the lens spins pretty easily here. So it's time for the phaco. I like to irrigate the surface of the eye. This also removes any bubbles. And then I'm going to lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, go in with the chopper. I'm removing the surface epinuclear material. This allows me to have a reference point of going under the epinuclear ridge when I do the double chop, and then pointing the phaco tip vertically, subincisionally. I bring both instruments together and crush the lens, and this divides the lens. I place the chopper out to the contralateral equator, pull it towards the phaco tip centrally, and this crushes the right heminucleus in half. I place a chopper out under the first quadrant. I pull it towards the phaco tip, and that crushes that lens piece. I'm using some vacuum to pull the pieces upward, and then using the chopper to crush the lens pieces against the phaco tip. Use a chopper to get out and around the second quadrant, pulling it up, and then I'm crushing the lens piece with the chopper against the phaco tip. I'm using high vacuum and a little bit of ultrasonic energy. I'm turning the second heminucleus in front of me, place a chopper out to the equator, crushing the lens against the phaco tip again, pulling up the third quadrant with a little bit of vacuum, getting around it with the chopper, crushing it against the phaco tip once again, doing successive mechanical fracturing forces with the chopper against the phaco tip, crushing the lens pieces into smaller pieces, and using that high vacuum. Placing the chopper out again around the fourth quadrant, pulling it against the phaco tip, crushing that fourth quadrant, again using successive mechanical fracturing forces, placing the chopper out to the equator again, crushing the lens piece against the phaco tip, and now all the pieces are gone. I grab the anterior lip of the epinucleus with a high vacuum, and you can see the epinucleus tumbles out quite easily. But it's important to reiterate, whenever I'm using high vacuum, I want to place the second instrument deep in the bag to make sure I'm protecting the posterior capsule. I remove the chopper with irrigation on with the phaco tip, and then I push BSS through the cannula, remove the phaco tip. I'm continuing to push BSS with my cannula to maintain some chamber stability here. Irrigate the cornea, remove the bubbles from the INA handpiece, and then enter and inflate the eye again. Starting subincisionally, removing the cortical material. I'm very confident because of this polymer tip. I'm able to go around circumferentially, and with pedal control, I'm able to tease off the cortical material with this high vacuum. Now that the cortex is removed, I'm switching to the polish mode, and I'm polishing underneath the anterior lens surface to remove any lens epithelial cells. And this gives me a little bit more confidence to go right up against the capsule and polish. If I try to go in the cortex mode, I might accidentally grab the capsule, and as I pull, I might stretch the zonules, which is not ideal. So the polish mode is really helpful. You can get right up against the capsule and really be more vigorous with the polishing of the lens epithelial cells without any worry about grabbing the capsule or stressing the zonules again. So I'm pushing BSS into the subincisional fornix to remove any potential cortical material. This is a fairly clean bag here. And then I'm injecting some cohesive viscoelastic into the capsular bag. And then I'm begin to polish underneath the anterior capsular surface. This is kind of a two-step procedure of really cleaning up the bag. First, I use the IA in polish mode, and then I'm using this capsule sweep, first polishing the left side and then the right side. And I'm really trying to make sure I don't go deep into the capsular fornix. I'm really trying to polish around the anterior capsular rim. I'm injecting my single piece acrylic intraocular lens into the capsular bag, but you saw I used the sweep to hold the eye as I did this. And then I'm going in with IA irrigation off first, freeing up each haptic separately, going underneath the optic, rotating the lens 90 degrees clockwise. I'm going in, tilting the lens sideways. This ensures that both haptics are in the bag. And now I'm gently polishing underneath the anterior lens capsule, as well as in the bag to remove any viscoelastic and any lens material. As you can see, with each step, I'm going very systematically and methodically. I'm not going in and out with a bunch of instruments unnecessarily. If I have a cannula, I use a cannula. If I have the sweep, I use a sweep. I try not to mix around too many instruments unless it's essential to switch instruments. Once I've cleaned the bag, I switch to viscoelastic mode and removing the viscoelastic in the anterior chamber. I'm using the BSS cannula to pulse the angle to make sure there's no viscoelastic trapped in the angle. And then I remove the INA and push BSS, and then I hydrate my incisions. So again, this is an unedited case of a medium density, medium pupil. I'm using mechanical fracturing, double chop, cross chop, capsular fornix hydrodissection, using the chopper to prolapse pieces out of the bag, crushing the lens pieces with the chopper against the phaco tip, using high vacuum and only intermittent bursts of ultrasonic energy. You can see this is a well-centered rhexis, a clear cornea, and the patient did well. As surgeons, we should never stop learning from our cases, and striving to be better will help us to be better for our next patients. So I hope this was helpful to you, and I thank you for your attention.